Hello, my name is Amit Gulati, and we'll now be talking about neuromodulation options for telemedicine visits. These are my disclosures. None of these should be pertaining to my topic today. We will not be covering any industry-sponsored devices. What I want to talk about today is really focusing on transcutaneous electrical nerve stimulation and some of the newer technologies such as inferential TENS and non-invasive high-frequency impulse therapy, or HFIT. Why do we want to talk about this? Well, we know that our interest may lie in some of these other innovative devices such as spinal cord stimulation and peripheral nerve stimulation, but we have the ability to provide electrical modulation systems via a world of telemedicine and virtual medications or medicine right now, such that devices such as TENS units, which have attachment of wires to a electrical stimulation device externally, and HFIT, which is some more novel devices which have their still external system with a battery source that is significantly smaller, but providing some newer waveform technologies. These devices can be obtained by the patient, and then the education can occur via a telemedicine visit. First, I want to cover transcutaneous electrical nerve stimulation, or TENS. Why do we want to talk about neuromodulation during telemedicine? Well, when we try to achieve pain relief, we generally think of things that we can apply pharmacotherapy-wise, such as opioids, which activate the endogenous endorphin system. From a regional anesthesia perspective, we may be able to give lidocaine, which provides a nerve block and stops neural conduction. We may be able to modulate the nervous system pharmacotherapy-wise with medications such as tricyclic antidepressants or anticonvulsants. More recently, we've been interested in trying to modulate the pain signals electrically. We've been doing this with various systems such as spinal cord stimulation, or SCS, or peripheral nerve stimulation, or PNS. But we can remember that we have been doing modulation electrically for many years transcutaneously, either by a tub of water with a electric eel or devices such that are at least 150 or 200 years old. The benefit of this is that we can teach these devices virtually or through a telemedicine visit. Some of the early devices in TENS had a constant direct current, such as 3 milliamps. Devices became more clever where the current could be adjusted so the intensity could be made stronger if needed to overcome the skin resistance. And some of the other device parameters were able to modulate over time. So some of the principles you have to be aware of with TENS units when you're educating a patient. Usually you will have multiple frequency choices. Patients will have a choice of a low frequency between 2 and 20 hertz usually, which has also been called acupuncture-like TENS. Now, at these low frequencies, you're able to contract a muscle. As your frequency gets higher, the muscles are unable to relax and contract again, and therefore muscle contraction does not tend to occur at much higher frequencies, but that at around 50 to 150 hertz, you're able to activate the sensory nervous system, such that when you put a TENS unit on at these frequencies on the skin, a patient may feel a prickly or a beating type feeling or various pulses over time. Now, these pulses or these frequencies can be modulated. Some of the things that can be modulated are the pulse width or the time that a patient feels that pulse. In general, we have thought in peripheral nerve stimulation that low pulses may preferentially activate A beta fast-acting fibers, and as the pulse width increases, there'll be more and more recruitment of various neurons. Some of the clever things that TENS units can do is change the pulse shape. Most commonly, we have a square wave shape where you have no feeling and then a complete turn on of the system with the intensity that's been measured is immediate. You can modulate that such that a sawtooth wave will generally increase the intensity to its maximal value that you have set. You can do this with sinusoidal wave as well. The intensity is the most common thing that most patients will change in a TENS unit, is usually in milliamperes, and this can be increased for patients to feel their sensation. There are some modifications or modes that a patient may choose from. The most common one is having a continuous pulse, pulse train, that's in the frequency that you choose. There is some high level of accommodation over time in this usage. And so you see different techniques such as burst stimulation, where you have a continuous pulse and then a delay where it's off, and then a continuous pulse or frequency again, and then it's off again. That delay can be set at certain time points. And also you have modulation, where you can slowly increase the intensity of each pulse and then decrease the intensity of each pulse over a finite period. And that can also change such that the intensity that a patient feels is not always constant. Clearly as the devices become more technologically advanced, you'll have different variation of these various settings. One of the other things you have understood about TENS units is that the device tends to be a goal-directed type therapy. Therefore, it has to be on for a patient to have pain relief. And there may be some duration of action after the cessation of TENS. But in general, most patients have to use TENS multiple times during the day and for certain time points. And this is not defined in stone. So in other words, protocols vary between practitioners, physiotherapists, physicians, and there's even within studies, this is not a constant occurrence. So it's possible that you might come to our clinic and have a patient have a 30-minute session and do this 4 to 6 times a day at a certain pain location, but the protocol may change and may vary to the patient's preferences and the education provided by the TENS provider. The basic tenet of how TENS units work is the gate control theory. We understand this as a simple network where as a pain signal enters into the dorsal ganglion and goes into its second order neurons down the spinal thalamic tract, the pain signal can be modulated by descending inhibitory neurons coming from the brain and traveling down to meet these second order neurons. Chemically, we do this with activation of the mu receptor, the use of endogenous opioids. However, this can be done in other ways as well. When a patient feels a sensation in the same pattern of in the same pathways that they're feeling pain, or a patient moves, therefore activating either A beta fibers for sensation or A alpha fibers for movement, those activation of those fibers may induce the descending inhibitory neurons to turn on and therefore turn off the pain signals that are coming in from the same location. This is the basic tenet of the TENS unit. However, we have some animal model data suggesting that there are some other effects of electrical stimulation. In this particular animal model, we make a skin incision in the rat and there's a retraction. The various inflammatory markers, interleukin 6, TNF alpha, and interleukin 1b are measured. The frequency that's delivered is 100 hertz at 100 microseconds, and there's parameters for 20 minutes a day and 40 milliamps. The first measurement is the von Frey filaments, and the idea is that with an incision, it is thought that more rats would draw when a von Frey filament is placed in the paw because of hyperalgesia and allodynia. It seems that if you apply a TENS unit, this recovers faster than a placebo TENS or natural history of an incision, such that at 30 days, a TENS unit will have the same effect as the sham in terms of the number of rats withdrawing from stimulus. More importantly, while we do see a decrease in mechanical allodynia, we see that there are changes in substance P, interleukin 6, TNF alpha, and interleukin 1b, such that in 14 or 30 days, our amount of the inflammatory markers have reached the level almost of sham. What this tends to show is that over time, the affected TENS may decrease inflammatory markers and therefore increase inflammation relative to an incision that is not treated with TENS. When you talk to our patients, we might think about using TENS for at least a 2 to 4 week time point, because it does seem that for a chronic effect to occur, we have to have continuous usage of TENS devices. The second question is does frequency matter? Looking at the rat tail flick test, which is temperature related. As the temperature is increased, a rat will flick its tail. And the idea is to put electropuncture at 2 different frequency, either 2 hertz or 100 hertz, and see if rats will tolerate more heat before they move their tail. And when use of electropuncture occurs, it turns out that most rats will tolerate more heat in the vicinity of 75%. And the idea now is to take this one step further. How about if we do intrathecal antagonists that are placed in the time where the TENS unit is on? Do some of these antagonists blunt the response that was created by TENS units? It seems that if you have a 2 hertz stimulating pattern, most of the intensity and the response depends on muscarinic and the opioid receptor. However, at 100 hertz, we have some more activity of the GABA receptors. Therefore, it is conceivable that in your patient population, low frequency or acupuncture-like TENS or motor stimulation may have a different effect for a patient's pain response than a sensory stimulation or 100 hertz. So when discussing different settings with your patient, have a consideration for trying both motor stimulation and sensory stimulation for pain relief. When you look at the data for TENS units and post-surgical pain is a population that has been well studied. Conventional TENS tends to be what's utilized most frequently. It's a high frequency, but a low intensity, so it's not painful. Acupuncture-like TENS is motor stimulation. And finally, intense TENS selectively activates small diameter A delta fibers using high intensity and high frequency, such that it could be painful. Then you reduce the threshold of this intensity such that it's almost painful, but not quite. When you look at the data for this population, we find that the studies are controversial at many points, but overall, most randomized controlled trials for thoracotomy and sternotomy, which has been well studied, shows improvements of visual analog pain scales in the range of 1 to 1.5 points on that scale. This seems to be consistent in other studies in orthopedics and in posterior fusion studies. It seems to be that the pain scale scores tend to improve 1 to 2 points. In our oncologic population, we see a similar effect in TENS patients in the cancer pain patient population. For functional improvement and VAS scores, while we see functional improvement, we only see a point improvement of 1 to 1.5 on a VAS and a numerical rating scale as well. What is notable in this situation, though, is that patients tended to improve in their function such that they could achieve more, and so some of the pain may have been resultant of the increased activity. Regardless, one of the issues with TENS patients is the continuous use of TENS. Patients are finding it difficult to put pads on, take them off, and do this every day for an extended period of time. If a protocol that you ask a patient to do is 4 times a day, they either have to keep their pads on throughout the day, or they have to take their pads on and off. And this can be cumbersome, especially with replacement of pads happens very frequently. So for TENS to be most effective, we see that data suggests at least 2 weeks of treatment, which is sometimes difficult for patients to do. But most importantly, it's very uncommon for patients to receive appropriate education on how to use their TENS unit. There are some newer devices that have presets that are available for patients, but just the placement of the pads and where to place a pad during a painful period is actually not usually taught. So when you consider a telemedicine appointment and want to teach a TENS unit, please consider where to put the pads for a patient. Also, which some of the settings that they can choose that might be most effective, such as a low frequency and a high frequency setting, and then deciding if they want to use something besides a continuous setting such as burst or modulation, and teaching them about the intensity dial and about the pulse width. If the patients have some understanding of how they can change their sensations, they may be able to get better efficacy and outcomes from their TENS device. More importantly, there are some technological limitations of TENS. First off, your skin is a significant resistor. The way TENS overcomes this is by increasing the current. For your deeper structures, such as subcutaneous tissues and nerves, and your muscles to feel the waveform of TENS, you're going to have to increase the intensity. As you do this, the skin may have a burn. It may be painful as a result because the neurons on your skin will feel a greater electrical field than the muscle, and therefore they might have pain actually on your skin. This may also lead to decrease in compliance. Obviously, there's some frequency limitations with these devices as well, especially that they can only run at low frequencies for acupuncture-like TENS up to sensory stimulation, usually in the vicinity of 200 to 300 hertz. Next, we will talk about inferential current and how this may overcome some of the limitations of TENS units. One of the things that's important to understand is that your skin is truly a capacitor. If you give enough energy to the skin, it will fill the capacitor, and therefore now you can overcome the resistance or the impedance of the skin and pass a field through it. So if, for example, if you run a frequency of 4,000 hertz or 10,000 hertz on the skin, eventually that wave will come through the skin. That frequency and energy will come through the skin a little bit easier than they would if you only ran a 40 to 100 hertz form like conventional TENS. Now, if you're clever about this, what you'll realize is that if you use some specific methods with two different pads across from each other and running at slightly different frequencies, in this particular case 4,000 and 4,100 hertz, that if the frequencies, when they touch each other, they'll cancel each other out. But because there's a slight variation in the frequencies, some frequencies will get through the skin and make it to the tissues underneath. Most of the frequency and energy will get canceled. However, few waves or pulses will be amplified. This is the beauty of inferential TENS, that if you use very high frequencies, you can overcome the impedance of the skin, but you can use certain methods to vary those frequencies such that certain pulses are amplified, and that amplified frequency can get through the skin. In general, for inferential TENS, that beat frequency we just discussed hovers between 40 and 100 hertz. But that does not mean this is limited to this. This is the design of the device that you're using, and there may be different settings for the inferential system that you choose. Regardless, two things that happen is that number one, it takes less energy overall to get through the skin because of the high frequency to get a 40 to 100 hertz wave into the muscle or the nerve underneath. Now, one of the other things to understand is that because I'm running such a high frequency on the skin itself cannot have a sensation because they're not able to open and close and have a sensation at frequency that would normally occur at 100 or 200 hertz, but at 4,000 hertz, similar to some other technologies that we have in peripheral nerve and spinal cord stimulation, you don't have sensation or conduction of a signal. Therefore, on the skin, it's less painful because it's almost like a numb effect, a numbing effect. Now, is there some data that suggests that this is truly happening? This is evidence from a group that looked at providing inferential system, having two pads with a current going across as such with my cursor, and having a grounding electrode. So an inferential system has to have a grounding electrode, and then measuring the voltage and the field at the skin, at the subcutaneous tissue, and the vastus medialis muscle at 3 points. The first point is in the middle of the inferential pattern. The second one is along the inferential pattern of one of the set of two pads. And the third one is outside the inferential pads. The hypothesis is that outside the inferential pads, similar to TENS units, you will not have electrical stimulation. However, along the path, you should have significant stimulation, and you will also have significant stimulation at the middle of the two fields that are being generated. In this particular case, the rectangular waveform was chosen for best neural stimulation, but there can be other waveforms used, such as a sine wave. What were the take-home messages? What we found was that a beat frequency of 4 Hz led to significantly increases in the voltage that the muscle and the subcutaneous tissue was exposed to. As you increase the frequency to 40 Hz and 90 Hz, you had a decrease in your volts at all 3 time points, or location points, the skin, the subcutaneous tissue, and the muscle. What was important was that there was not much attenuation between the skin, subcutaneous muscle, and the subcutaneous tissue and the muscle, such that even though there was slight attenuation, overall you saw the same effect. Most importantly, we saw that the voltage measurements outside the location of pads, shown in this curve here, was actually significantly more than inside the location of the pads, which was not part of the original hypothesis. This seems like with inferential TENS with significant high frequencies, you get a larger area of stimulation than even where the pads are located. Most importantly here, a system that pre-modulates that frequency, in other words, in the cancellation of 4,000 and 4,100 Hertz occurs in the device, and then the resultant waveform, the frequency between 40 and 100 Hertz is sent to the pads, shows that you have significantly less voltage or energy making it to the skin. This would be more similar to a TENS unit, which will only provide 40 to 100 Hertz frequency. It's similar to what the pre-modulation device would do for inferential TENS, suggesting that inferential TENS at the same level of energy can get an increased response or voltage through the skin to the various tissues. So what are some of the limitations of inferential TENS? Now, the subcutaneous and the deeper structures will see a slightly higher voltage or energy to their tissue, but the frequencies will still be in the 4 to 100 Hertz range, depending on the device you choose for inferential TENS. So in the end, you'll have a slightly increased voltage with less current needed to achieve that voltage, but you'll have a TENS-like effect. And now you have a patient that has to have 4 pads and a grounding pad for their pain relief, and you're going to have similar compliance issues in this patient population. And even though the data is not as robust as it is for TENS units, the data is similar with regards to changes in pain scores between the 1 to 2 point VAS or NRS pain scale data points. So we have some advances in technology, specifically high-frequency impulse therapy, that takes some of our knowledge of what some of the new waveforms are doing in spinal cord and peripheral nerve stimulation. Now, the evolution is such that, similar to what's happening in spinal cord stimulation with 10,000 Hertz, we now think about what can happen with ultra-high frequencies to a neuron. In this particular case, the primary component of the HFIT waveform is a really broad-based high frequency. There's some specific attack phases that you can choose that may preferentially activate or deactivate certain receptors, may actually modulate some of these receptors with certain attack phases of 100 to 300 nanoseconds in terms of theoretical opening or closing of receptors. But what's most important at this frequency is that, similar to inferential TENS, you can fill the capacitor of a skin, and now you can bypass it. Because the skin has reached its capacity, it's going to let the rest of the energy through. That means that now underlying muscles or nerves are exposed to whatever frequency you choose. Well, in HFIT, we're choosing frequencies in the 10 to 100 kilohertz range. So therefore, your tissue is not going to be exposed to this frequency frequency waveforms. This is in contradistinction to a TENS or inferential units, which will have 40 to 100 hertz. In an HFIT system, your tissue will be exposed to 10 to 100 kilohertz. What's special about HFIT is that there's still a secondary component for most of these devices. They'll still take advantage of TENS units and what inferential devices do and provide a baseline frequency for the skin between 2 and 130 hertz usually for certain devices. There'll be some different protocols that you can achieve with this. They'll have a TENS-like effect. This is not a beat frequency like it is for inferential TENS, but more like a true TENS frequency that can be made in various forms. To show this graphically, you'll see here that you have a ultra high frequency running on the top of a primary pulse that is working as a paresthesia type device. Now at ultra high frequencies, the skin may be numb, but in general, patient will still have some form of sensation with their conventional therapy that will activate A-beta sensory fibers, and the numbing effect may result in the subcutaneous or the lower or the deeper structures. What's interesting is what the effect of the 10 to 100 kilohertz frequency is. It does not seem to really affect large things such as a neuron as A-beta sensory fibers, but what it does seem to affect is the ion channels that are involved in the neurophysiology of conduction of a nerve. What are we referring to here? What we see is that if you expose this is an animal model, and if you expose the potassium ion channel to this ultra high frequency, what you see is that you see kinetic changes in the vibrational, the conformity of the actual receptor, such that it is more likely to open as a result of a high energy frequency that is making the receptor vibrate. The data shown here shows that in this particular animal model, the time constant or the time a channel needs to open is much quicker than in the control panel. But what's most important here is that if you specifically concentrate on the potassium ion channel, if the potassium ion channel is dysfunctional, it's more likely to be normal functional or hyperfunctional as a result of activation. What does that mean in the chronic pain population? It does seem that the potassium channel is involved in the chronic pain syndrome, such that it's either downregulated or is not as active as compared to the normal population. Therefore, when the potassium channel is not as active in the normal population, a neuron tends to be depolarized. That makes it hyperexcitable. The idea with a conformational change in the potassium channel, even if it's downregulated, is that the potassium channel will more regularly open and reduces hyperexcitability by returning the resting membrane potential of a neuron back to its normal minus 70 to minus 90 millivolts. This effect is shown currently in the animal model for chronic pain, and hopefully further research will confirm this in future trials. But nonetheless, we have now a system that might be affecting the actual excitability of various channels, ion channels specifically. In particular, the potassium channel, it tends to be more leaky than the sodium channel. So you'll see the electroactivity perhaps being more akin to a change in potassium as opposed to a change in sodium. When looking at these devices in the clinical data, this was presented in a conference in 2019, looking at a subset of a randomized controlled trial for chronic low back pain patients. What we see is a simple improvement in pain scores in this patient population for a HFIT therapy patient placed at the lower back versus a device that a patient does not feel, also known as a sham device. This sham device did have a patient improvement, almost a 2-point reduction. However, the use of HFIT showed a 4-point reduction as a mean in this patient population. Perhaps what's most important is that if you consider 30% pain reduction in this patient population, the responder rate is greater than 85%, which is fairly significant if you consider the 30% pain reduction as a significant barometer of pain relief. Similarly, when you look at functional improvement, this particular trial looked at the timed get up and go test to see if over time, would the patients have an improvement in their function. What you see that sham does tend to improve um, their ability to get up and go and make this a faster, make this faster than at time point 0, but HFIT has a significantly better improvement in function compared to the baseline and also compared to sham in this patient population. So now we have a device that has not only a TENS-like effect, but a secondary effect with ultra high frequencies, which may show improvement in chronic back pain patients and hopefully in other trials in the future. But not only do you have improvement in pain, but you have improvement in function as well. So in conclusion, with telemedicine, we still have neuromodulation systems that are viable. A lot of the success of these devices depend on education, and TENS units, IFC devices, and HFIT devices are available for patients through various vendors that can either deliver to their residents. This allows a practitioner to provide education via virtual setting, but still allows us to give neuromodulation as a treatable system for pain relief. HFIT is a promising new technology that's still transcutaneous in nature, but has a specific new mechanism of action using ultra high frequencies. And what the data is currently showing is that there's a high patient success rate with VAS scores that are larger and their means than TENS units or inferential TENS, which is a major positive. There are different acute and chronic pain targets that are under investigation with these devices, and this might lead to a revolution in the use of transcutaneous electrical stimulations for our patient population. Thank you very much.